Okay, so we will start because we always start on time, irrespective of age. So welcome back. For certain reason, we had been a little irregular. Rather, we were not organizing the classes. So now onwards, every Thursday was 7 p.m. We would be back with the classes, online webinars of critical care nephrology, and we'll try to come up with practically relevant topics itself, and we will try to delve deeper into those topic itself. So I thank Dr. Gaurav Singh to agree to take the initial step of restarting the classes itself. Dr. Gaurav has done his DM nephrology, and now he is a critical care nephrology fellow in Sir H.N. Reliance Foundation Hospital, and he is going to speak today the paradigm shift in HRS AKI. What are the new things that have been included in the 2024 guidelines? A little bit on the evolution of the concept of HRS itself, and whether we should be more proactive in certain therapies like albumin. We should be more accelerated towards the vasoconstrictor therapy. So he will give us a clearer idea on what's going on, and maybe we will also discuss a bit that why these changes did happen, what are the physiological basis of these changes that had been propagated and accepted, and maybe whether this would bring a much more better outcome of what HRS presently is now. And so over to you, Gaurav, and our other mentors and clinical experts like Dr. Pandit and Dr. Rushi Deshpande would be joining pretty soon. Dr. Dash has excused himself. He will still try to join because he is in outside Bombay. But as we said, that this was more imperative to initiate. I think once the process starts, everyone will catch up, right? So that's an over to you, Gaurav. All
Yeah,
the
so
best.
good evening, everyone. Thank you, sir. Good evening, everyone. I am Dr. Gaurav. I am a critical care nephrology fellow at Reliance Foundation Hospital. And today I'll be presenting on the topic of hepatorenal syndrome, its latest guidelines and updates on the treatment. So this I have taken from 2024 International Club of Ascites and Acute Disease Quality Initiatives guideline. So what is HRS? What is its pathophysiology? So instead of HRS, we should actually call it as a hepatocardiorenal syndrome because it's not just the kidneys, it's the heart also which gets involved in HRS. So whenever there is liver cell failure, there is portal hypertension and splanchnic vasodilation, which leads to reduced effective arterial blood volume and renal vasoconstriction. This renal vasoconstriction will cause RAS activation and sympathetic overactivity, which in long term leads to cardiomyopathy, which we call it as cirrhotic cardiomyopathy. There are also a lot of chemical mediators which are involved in the pathophysiology of HRS, which are DAMs, that is damage-associated molecular patterns. There are also gut dysbiosis, which we call it as pathogen-associated molecular patterns. Pro-inflammatory cytokine release, such as IL-6, IL-1, IL-12. Relative adrenal insufficiency is also seen, and in some cases, cholemic nephropathy is also seen. So what has changed since 2021? So previously, we knew HRS by type 1 and type 2. Type 1 used to be more aggressive and fatal, whereas type 2 used to be more indolent and gradual. And before, like to call HRS a diagnosis, we used to give 2 day of albumin trial, and HRS was mainly a diagnosis of exclusion at that point of time. But in 2024, like after like a lot of trials, it has been found that the 48-hour albumin trial is like it actually delays the time, and time is the tissue in this case. It delays life-saving vasoconstrictors, and it risks severe fluid overload in the euvolemic patients. And now that HRS has been classified into 3 different categories. One is HRS AKI, HRS AKD, and HRS CKD. The HRS AKI is considered when the derangement in the creatinine value or the renal dysfunction is less than 7 days. And if it is between 7 to 90 days, it is HRS AKD. And if it is more than 90 days, it is HRS CKD. So we are now also considering the previous structural kidney impairment in this new category of HRS, new classification of HRS. So now I'll be telling you the modern HRS mechanism that we have added in 2024 category. The mechanism that is present in the red that we are already knowing, that portal hypertension and liver cell failure leads to splanchnic vasodilation, which leads to reduced effective arterial volume, leading to renal vasoconstriction, which causes actually a functional renal impairment, not a structural renal impairment. But now in the latest HRS guidelines, they have also added that there is some kind of structural impairment as well. So how it happens? So whenever there is CLD, there is some amount of bacterial translocation from the intestines, which leads to increase in the PAMPs. Some amount of necrosis is also there, so which also releases DAMPs. It causes systemic inflammation, cytokine release, and oxidative stress, which leads to direct tubular impairment. So this tubular impairment leads to acute tubular injury and later on acute tubular necrosis as well. So this acute tubular injury can now be measured and through a marker known as NGAL marker that we'll discuss in the later slides. So again, this slide shows the diagnostic criteria of the latest guidelines, ICA guidelines. So there has to be cirrhosis along with ascites in the patient. The AKI should be there as per the latest KDIGO 2012 guidelines. And we have to also exclude other causes of AKI such as shock, other use of nephrotoxic drugs, or any previous structural kidney injury. So if there is any kind of previous structural kidney injury, then we call it as HRS CKD or AKD. But to call it as HRS AKI, there shouldn't be any previous structural kidney injury. There is also a thing which we call it as a sarcopenia cavid. As in the CLD patient, there is low muscle mass, serum creatinine more than or equal to 2.5 milligram per deciliter, severely underestimates renal disease in these patients. So the 2024 mandate is tracking dynamic serum creatinine changes over the fixed thresholds. Previously, the serum creatinine, like static serum creatinine values were used to be taken, but now we trace the serum creatinine over a period of time. So the KDIGO 2012 guidelines, the AKI criteria are as follows. The serum creatinine increase more than 0.3 milligram per deciliter within 48 hours or 2 days, or increase in the serum creatinine by more than 50% from the baseline over a period of 7 days, or urine output less than 0.5 ml per kg per hour for more than 6 hours. So the thing is, whenever there is any kind of renal injury, the serum creatinine doesn't rise very rapidly. So one has to actually see for the urine output very rigorously in an ICU patient, because it takes time for the creatinine to go up. So even if like you see a patient who is anuric or oliguric since last 3 to 4 hours, you have to keep an eye for like on that patient to label it as HRS and start the treatment early. So this slide shows the difference between the 2021 and the 2024 criteria. The AKI threshold, the guidelines has still remained the same. In the volume challenge earlier in 2021 guidelines, we used to give albumin for 2 days, but now it has been removed. In the latest 2024 guidelines, adequate resuscitation has to be done if indicated. Routine albumin is not indicated. The albumin is only indicated in SBP, in HRS with SBP sepsis. Plus, in the prerequisites, the cirrhosis has to be present as per 2024 guidelines. So HRS time is tissue. We don't have to wait for 2 days as it was earlier indicated. Once we label the patient as HRS clinically, the first we have to do is the resuscitation and followed by vasoconstrictor therapies. So we do clinical resuscitation with the help of like clinical examination, point of care ultrasound, radiological imaging. And once the diagnosis is confirmed, immediate terlipressin or other vasoconstrictor therapy such as noradrenaline has to be started along with albumin. So yeah, early vasoconstrictor therapy reverses AKI. The 2024 guidelines recognize that delaying definitive therapy for an arbitrary 48-hour albumin trial harms the patients. Diagnosis and therapy initiation are now accelerated. So faster AKI reversal and improved outcomes is there upon immediate terlipressin therapy. So this is the flow chart showing once the diagnosis of AKI has been made, you start the treatment. For the diagnosis, you have to first check for the volume like status, plus rule out other causes of kidney injury, and then start the treatment. So now a new thing. So if a CLD patient is admitted in the ICU, first we have to see if there is presence of cirrhosis or not. So if there is cirrhosis along with ascites, we have to see if the creatinine is normal or not. If the creatinine has jumped, so the how much is it has jumped. So if it has increased by more than 0.3 in last 2 days, or by more than 50% in
So
last
you have
7
an
hours.
objective diagnosis of cirrhosis and ascites itself, which can be easily done by an ultrasound, history, and all other. So you need a structural change and an objective presence of ascites, and then you are going for the KDIGO AKI thresholds. So
Yes,
what
sir.
is the quantification of the creatinine jump, right?
Yes, sir.
Okay.
Plus, we have to adequately resuscitate the patient within 24 hours, which might include crystalloids and colloids. And if the patient is euvolemic, we don't need any like further resuscitation or any like
Yeah.
fluid therapy, because it might put the patient in the fluid overload. Plus, we have to also rule out the causes of any shock or any like nephrotoxic agents or any
Nephrotoxin or
previous
parenchymal
parenchymal
disease.
in
You see, nephrotoxin parenchymal diseases are easier to A. The
yes,
major A is your septic shock, mostly
yes,
the sepsis, because other form of shock can be also you can rule out easily.
yes,
But
sir.
the major problem happens in the sepsis itself. That's
And
the most closest thing with HRS itself.
And a lot of
Uh,
patients in our ICU are having either LRTI or like
And you have
trauma
written
related disease.
prioritize biomarkers. So are there any specific biomarker? Are you covering it in your
Yes, sir.
subsequent
So now
slides?
NGAL has come, sir. Urinary NGAL.
Okay, please carry on, carry on.
So now the new novel biomarker, which is urinary NGAL, has come into the picture. It differentiates between the functional HRS and the structural HRS or the structural impairment. So what is NGAL? NGAL is a neutrophil gelatinase associated lipocalin. It releases from the tubules. So once there is like whenever there is stress to the tubules or hemodynamic shifts or inflammatory insults, the tubule starts releasing NGAL. It is a small protective protein released from the tubules, and it is directly released into the systemic circulation and also to the urine, and it acts as an immediate and quantifiable biomarker to the amount of the structural injury. So in the pre-renal AKI, it has been seen that the amount of just the pre-renal AKI, it has been seen that the amount of the NGAL is less as compared to seen in the like ATN because of like some other causative agents. So in case of pre-renal AKI due to HRS, the NGAL amount, the NGAL level is slightly over the threshold, over the like reference range. And in cases of the severe ATN, due to secondary agents, the levels are quite high. So
So
how?
you are implicating that there would be differential levels or differential thresholds for pre-renal or ATN as well as the HRS itself. But is
Yes,
it
sir.
there, or you are
No, no,
saying that it would come eventually?
the studies have been done, sir. Various studies have been done that pre-renal AKI versus the renal AKI, that is the ATN. So
Right.
in the renal AKI, which we call it as ATN, in that the NGAL levels are very high, whereas in the pre-renal AKI, the NGAL levels are the range is on the like lower side.
But it is not universally accepted now.
Not yet
So,
universally
in
accepted,
not
sir.
universally, but if we are doing NGAL, so the implication is that if you have a very high levels from the baseline value, then it is more chance that it is an ATN. And if you have a higher value, but not many times from the baseline, then it could be more pre-renal could be the cause,
Yes,
right?
sir.
So it can
Yes, sir.
give us a little bit of idea that what would be depending upon the quantum of increase.
Yes, sir.
Is
And
that
it,
what you meant?
yes, sir.
Okay, please carry
And
on.
it can also like help in the prognostication, because whenever there is severe tubular injury, the recovery might be delayed.
Fair enough. I think we will have a separate class on the particular NGAL and its changing paradigm. As of now, I think this is good enough for the viewers and students. Please carry on.
So how the urinary NGAL is better over just the serum creatinine alone. So there are various flaws of the serum creatinine. In case of impaired liver function, there is reduced baseline creatinine level. Plus, there is severe muscle wasting in CLD patients, which can also mask actual kidney function. And some assays are confounded by elevated bilirubin and total body volume variations. Whereas in case of urinary NGAL, it directly measures tubular structural injury rather than downstream filtration rates. It is not confounded by muscle mass or liver synthetic function. It responds rapidly to acute injury, whereas creatinine takes some time to rise after an injury. So this we have already seen in the previous slide. Whenever you are suspecting AKI in a cirrhotic patient with ascites, you have to first check for the staging, like as per the KDO guidelines, and whether if the and to see for the volume status, if the patient is euvolumic, you directly jump to the diagnosis. If the patient is hypovolumic, do adequate volume resuscitation with the help of either colloids like albumin or crystalloids, and reassess and start the treatment. Don't delay. So once the diagnosis of HRS is confirmed, we have to start the vasopressor therapies. So there are mainly two vasopressors. The first one is terlipressin, the other one is noradrenaline. If the patient improves, we will send the patient for the liver transplant, because the definitive therapy is liver transplant in HRS. And if the patient is not improving, we either escalate, we either start RRT or we escalate the patient for the liver transplant in
Fair
an
enough.
urgent manner. Yeah.
Fair enough. Please carry on.
So in the fluid resuscitation, we follow this algorithm. If the patient is having general volume depletion, start with the crystalloids. There are various balanced salt solutions. The salt solution that we use are carbolite, plasmalite. The cheaper ones are ringer lactate. In case of spontaneous bacterial peritonitis, like associated SBP, 20% or 25% albumin is preferred. And whenever there is any kind of GI bleeding, for the adequate resuscitation, PRBC should be used. So now coming to the vasoconstrictor therapy. So terlipressin is the one which is considered to be the first line in non-ICU patients. So how to administer terlipressin? So it can be administered in two ways, either by continuous IV infusion or by bolus therapy. So bolus is not frequently recommended because it has got its own adverse effects, such as cardiorespiratory adverse events in the form of MI. And it is also contraindicated in various conditions such as unstable angina, ongoing MI, hypoxemia, arrhythmias, uncontrolled hypertension. So we use IV, continuous IV infusion. So the dose is 2 to 12 milligram. 12 milligram is the highest dose. 12 milligram over period of 24 hours IV infusion is preferred. It can be combined with 20 or 25% albumin as well. So when to escalate the dose? Whenever after starting the terlipressin, if after 24 hours, if the serum creatinine has not decreased by at least 25% of the baseline, the dose of terlipressin should be increased. It can be increased up to 12 milligram per day. And now coming to when to stop the terlipressin. So there are five checklists. First is the serum creatinine if it returns to less than 0.3 milligram per deciliter of baseline, or maximum tolerated dose fails even after 48 hours of the therapy, or if there is some kind of coronary ischemia or pulmonary edema that occurs, or if we started renal replacement therapy. And sometimes even after 14 days of maximum therapy, there is even if there is response or no response, we have to stop this terlipressin. So whenever there is, when the terlipressin is unavailable or contraindicated, we have to use other vasoconstrictor agents. These are norepinephrine and midodrine. So norepinephrine is the vasoconstrictor of choice in the ICU because it requires careful monitoring and a central line. So the dose is 0.5 to 3 milligram per hour, and it has to be increased every 4 hours if the mean arterial pressure has not increased by 10 millimeter of Hg from the baseline. And the efficacy has been seen comparable to the terlipressin for the HRS reversal in many trials. And terlipressin remains superior, it has remains superior specifically in the ACLF. And midodrine, along with the octreotide, is considered to be a third line agent. It has to be used strictly if other IV pressors such as terlipressin and norepinephrine are not available, or it is not possible to give. The efficacy is inferior. It is less as compared to terlipressin or norepinephrine. So what are the contraindications to terlipressin? First is severe coronary cardiovascular disease or coronary artery disease, such as unstable angina, congestive heart failure, pulmonary edema, or severe peripheral vascular disease. Serum creatinine more than 5 milligram per deciliter. ACLF grade 3, hypoxemia, like SpO2 less than 90%, and pregnancy. Terlipressin must be avoided or stopped in the ACLF or hypoxemia until patient improvement is observed, because it has been seen that in the patients who are having grade 3 ACLF or serum creatinine more than 5, there is less of its benefits and more of its side effects because of the toxicity. So where is the role of albumin in HRS? So first, it helps in volume expansion. It maintains effective arterial blood volume. Second, it helps in endothelial repair. It reduces endothelial dysfunction. It also binds to vasodilators like nitric oxide and other harmful cytokines. So it has also got a toxic scavenging property. It also improves cardiac inotropy, and 40 gram per day is recommended to achieve these synergistic effects of albumin. So now there is also a debate between how much albumin to use. So efficacy versus pulmonary edema in sepsis. So patients in the HRS with sepsis, there is like albumin can act as a double-edged sword. So the rationale behind giving albumin is that it binds PAM, that is pathogen associated molecular pattern. It reduces systemic inflammation also. It expands effective arterial volume. But if we give, like if too much albumin is given, it can alter oncotic pressure, and it frequently triggers rapid pulmonary edema. Multiple trials such as ANSWER and ALBIOS trials have shown mixed results for the non-SBP sepsis. Short-term hemodynamic improvement is there, but no significant impact on the RRT avoidance or mortality has been seen when we were giving albumin in non-SBP sepsis HRS patients. So the 2024 guideline rule is that we have to titrate albumin based on hemodynamics daily, and do not use standard fixed dosing if volume status does not support it. So daily volume assessment has to be done either clinically or through point of care ultrasounds. So once we start the terlipressin, how often and what things we need to check? So serum creatinine has to be checked daily. ECG and troponin again has to be checked daily as per the guidelines, because there is always a risk of cardiac ischemia, which is associated with terlipressin. So what are the red flags in giving terlipressin? So hyponatremia and cardiac dysfunction. So if whenever if cardiac dysfunction is suspected, like immediate echocardiography should be done and cross-specialty consultation should be given. Again, the contraindications are ischemic conditions, coronary artery disease, pregnancy, and we have to take like caution in elderly populations. So the bridge to liver transplant in HRS are having two pillars. The one is the vasoconstrictor therapy and the other one is the RRT. So today I told about the vasoconstrictor therapy. The other pillar is the RRT, which we usually do are like SLED, sustained low efficiency dialysis, and the other one is CRRT, which is a more like prolonged version of RRT, which is continuous renal replacement therapy, and it is a very big like topic. It will discuss in the future lectures. It again needs a like good amount of time to explain. There is also a MELD paradox. So vasoconstrictors lowers the serum creatinine, effectively lowering the MELD score. So in the regions with long waiting lists, successful medical reversal of the HRS AKI might ironically delay transplant priority, because like once the creatinine is reduced, the MELD score decreases. So the patient goes back or like goes down in the transplant priority list. So what to be done if a patient gets discharged from hospital after the HRS? So if a patient is a transplant candidate, you should integrate like nephrology and hepatology on the subsequent follow-up. You have to see if the patient is having if the patient becomes a CKD patient or not. Because if patient becomes a stage 4 or stage 5 CKD, he or she will need a simultaneous liver kidney transplant, and just a liver transplant won't help. So you have to optimize the nutrition and physical therapy and monitor the patient until the transplant. So after a period of 30 days of discharge, you have to check for the kidney function, and a formal assessment for the CKD has to be done at a 90-day period, because there is a high risk of like recurrent AKI and like de novo CKD in these patients. Around 15 to 25% of the patients of HRS becomes a CKD patient. And if a patient is a non-transplant candidate or is a not fit for a transplant, palliative care has to be given, and goals of care has to be discussed with the patient's relative. Symptomatic and all the conservative management has to be done for the patient. So again, in like I would like to reiterate the 2024 ADQI and ICA guidelines. So they have revised the staging based on the dynamic AKI staging, the latest, like through the latest KDIGO 2012 guidelines. The coexistence has been accepted now. It has been acknowledged that the HRS fundamentally coexist with structural injuries like ATN and CKD. Biomarker integration has been done. Urinary NGAL has been incorporated into the diagnostic framework to guide therapeutic pathways. And yeah, time sensitivity. We have removed that 48-hour albumin mandate. Early treatment initiation dictates survival outcomes. Early intervention prevents irreversible multi-organ failure. So, what are the 5 key takeaway points? First, we have to use the KDIGO guidelines and the urine output criteria for early AKI detection. Then we have to skip for that 48-hour wait list for the albumin trial. We have to assess the volume daily and guide the fluid choice as per the clinical status. We have to optimize early pressing. Better to use continuous infusion rather than the bolus. We have like escalate at 24 hour if the serum creatinine has not dropped by 25% from the baseline, and plan the future therapy or treatment early, because this vasoconstrictor therapy and RRT is just a bridge. Definitive therapy is liver transplant, and it has to be done as early as possible. So in the next next sessions, we can discuss with the CRRT, because a lot of development has been done in the CRRT, cytosorb and other hemoperfusion therapies have also been tried in HRS patients, such as
So I
HH.
think this is the good summary checklist, right? Creatinine and urine output criteria for early AKI detection, right? And I think that you have given a very nice diagnostic A, where you have to structurally prove cirrhosis, measure creatinine, give a quick volume resuscitation. Don't have to wait for the albumin 48 hours therapy and others, and directly progress towards the diagnosis, right? Then you have given an idea that what should be the fluid choice by specific indication. Actively, obviously, you will not put your patient into a risk of pulmonary edema itself. And you have also divided that whom to whom.
So I had a question, like when you said that as the if the patient is oliguric, we need to act proactively and rather than waiting for the creatinine to rise.
Yes,
So
sir.
if the patient is, because what in ICU what people usually do is, if the patient is euvolemic and oliguric, so they tend to give a diuretic challenge. So is there any role of this diuretic challenge in HRSAK, or should we just skip that step and start replacing albumin?
Sir, regarding the diuretics,
Uh,
in the guidelines they have not mentioned, but like many expert opinion, like I've seen, they have they have tried diuretic in for the first 24 hours, and then
okay.
even if there is no diuresis, uh, early initiation of the like RRT or like early pressing should
Uh-huh.
be that. But sir, what I feel is first, like we have to make the patient euvolemic and then like
Yeah, true,
give a
true.
trial of diuretic, because diuretic won't harm.
Okay.
won't harm until unless the patient is like hypo.
Hypovolemic.
Yeah.
Okay. And second question would be like when you say ki 40 to 50 grams of albumin per day, which practically it means 20% albumin BD or 25% albumin BD. So do you recommend any specific duration for the infusion? Because all ICUs have their own duration. Some of them give over 3 hours, some over 4 hours, some at 10 ml per hour. So what would you recommend for the duration of one albumin infusion?
So ideally, like 20 ml per hour, like it has
So
again it has again
So,
not been
so, so, so
much,
over
yeah,
five
over five
hours
hours.
usually.
Yes.
No, well, I'm just asking like what is the usual practice in nephrology? Like, if what would you recommend if
Like
albumin is
we
given?
even like whenever you used to give during dialysis or
Huh?
other like other extracorporeal therapies, we give over 25 hours, like 20 ml per hour.
You get 20 ml per hour.
Yeah.
Okay. All right. Thanks.
Couple of questions and comments that one is that patient should be off diuretics for 48 hours for diagnosing HRS. I think it's more of a clear instruction, which we agree.
That, yes, sir.
Anirban is saying that resuscitation with albumin. What did you mean by it?
So it is resuscitation with the albumin has to be done in the either like HRS with SBP sepsis. Because in the because albumin has been found to be helpful in the SBP and not
So,
all other forms of sepsis. It is
okay.
not contraindicatory. It is
Nah,
like if the patient is either like if albumin is indicated in those hypovolemic patient or hypoalbuminic patients, then we can use albumin. It is not like it is not contraindicatory.
Yeah,
It can be done.
so Gaurav,
Yes.
when you say ki albumin resuscitation, do you mean 20% albumin 100 ml to be given, or dilute it with the 500 ml of normal saline and make it 4% albumin or 5% albumin and then give that 500 ml of volume?
Sir, in the guidelines, they have mentioned 20% or 25% albumin only. So, and they have actually not mentioned whether it can be diluted or not. But most of the times, they use this 20% only, and over a period of like few hours.
Okay. Right.
any question
Hello.
from our
Yeah.
other
Yes.
viewers?
Yes, Dr. Manish here, sir.
Manish,
Uh,
please.
yeah, Dr. Gaurav, you mentioned about the role of urinary biomarkers like urinary NGAL and cystatin C to differentiate between HRS, which is type of renal ATN. So if it is not available, it is they are costly and not available in most of the time, then we don't have predefined cutoffs. So can we still rely on that urine osmolality, urine sodium, FENA to differentiate between HRS and ATN? They are still in the guidelines or
Sir, it
not?
is still there. It is not been removed because the FENA and the this urine spot sodium and all those tests, they actually like differentiate once it has been like clearly established whether it is ATN or pre-renal. So in this section in the HRS, whenever there is structural impairment also in the form of acute tubular injury, the ATN has not pursued at that time. Like it is still like we still get some time. But whenever this thing like persists for long period of time, it gets converted into ATN, and then later on patient can become into CKD. So it tells at what stage the patient is, whether it is just the like early in case of early HRS, it is just a functional impairment of renal function. It is not like the structural impairment or structural injury has occurred. But later on in the like later stages of HRS, it becomes like it is function. It is a hybrid of phenotype we see, which is like
Okay.
functional impairment as well as structural impairment. And if it persists for more period of time, it converts like it gets converted into AKD and then CKD.
Okay, got it. And about that albumin resuscitation, you said it is just that the albumin, it is like a fluid challenge only, na? We want to rule out pre-renal AKI. It
Yes,
is like just like that, na, albumin resuscitation. So
yes, sir.
that's why they have removed that in criteria so that we can also give other fluids, na, crystalloids apart from albumin.
Yeah,
Yes,
7
sir.
o'clock. You are
Definitely.
already
Actually, they
along.
have seen that crystalloids and colloids have been found to
Better.
be equally good. Albumin has been found only better in cases of either like as this thing burns or like I'm just not this is not a
Or
HRS
SBP.
like burns or HRS with SBP. Yeah.
Okay. Okay, thanks a lot.
And we need to maintain the patient in the euvolemia just to exclude that there is no other like parameter or confounding thing which is causing this renal dysfunction. So it is a component of HRS which is causing the renal dysfunction and not not the volume depletion. That's why we do volume repletion before diagnosing HRS through
Okay.
crystallographics or colloids. Because
Hi.
this nitric oxide and all those this molecules, these are not get like metabolized by the liver, and there is splanchnic vasodilation also, and like portal hypertension. These all causes renal vasoconstriction and then RAS activation. It will then further aggravate the situation, the uremic toxins and all those things.
Any other questions?
Yeah, sir. Hi, Dr. Raghu here. Dr. Gaurav, I have one question regarding decision making in initiating CRRT and about the biomarker you mentioned. Let's take one clinical scenario. I have a patient with HRS, patient having a mild drop in urine output, and the baseline creat started increasing. I started with albumin resuscitation and NORAD. I sent urinary NGAL. The consecutive values are persistently high. How long I can wait to initiate my CRRT? Is there any timeline?
Yeah.
Like still, if the urine output is preserved and the patient is transplant candidate, how will you go
Yeah,
about it?
so yeah, it's a nice question. So it is acid like hyperkalemia, resistant hyperkalemia, fluid
Yeah, yeah.
overload,
Leave that routine indications of dialysis. That's we will go ahead. I am just
yeah.
want to know in HRS perspective, without having acidemia, hyperkalemia, but the patient having a rising creat with low urine output, with persistently high urinary NGAL, with shock, with sepsis eliminated. When should I go for CRRT if the patient is a transplant candidate?
If the patient is hemodynamically unstable, you can start CRRT right away. There is
Okay.
it's like, and if the patient is like
Now, I think the
on high,
question should be put in such way, Raku, is that not only when should you, but whether there is a certain advantage of initiating CRRT2, right? Because if there are no routine indications, right, AA, IOU sort of your question is that, but your patient there is a lesser urine output and obviously the biomarkers are on the higher end. So when to start? And if there are any advantage to start CRRT. Gaurav, your comment on this.
okay, so if
We
there
will
is
push now.
decreasing urine output, and even if like for 48 hours there is no improvement in the like urine output or the serum creatinine, and if the patient is like hemodynamically getting unstable, we can start with SLED or CRRT. SLED to be done in the patients who are either like at the verge of hemodynamic instability and that like the NORAD has not been started yet. And for this, like in the patients who are hemodynamically unstable, we should start with the CRT because early initiation has got better prognosis.
Asking. Gaurav, the question is also, I will put it in a different perspective. Does CRRT give a certain advantage, like your removal of certain cytokines or others, which might give a little benefit for reversal of HRS itself? Is
Yes,
there
sir.
anything that we can think of it?
Yes, sir. So, like CRRT has got a good amount of middle molecular clearance as well. So the one which we are using are Fresenius, like the multifiltrate, and the other one is Prismaflex by Baxter. So the one with the Fresenius, the filter that we use is AV600S. That has got better middle molecular clearance over the Baxter M100 dialyzer membrane. It has got better middle molecular clearance. Around 20,000 Dalton size molecules are also removed, and a lot of cytokines come into that category. So that is also can be used, and it is preferred over the SLED.
We will keep a separate session on this, that the indication and mechanism of CRRT in acute decompensation of a liver patient, be it your
Yes, sir.
HRS or ACLF. I think this is a very, very important aspect. In fact, it may not suffice. One session may not suffice, but definitely we will cover this. Raku, any more question?
Sir, in case if the patient presents with severe acidemia and hypokalemia, will you prefer CRRT or SLIT?
If patient is severely if patient is hemodynamically unstable, then I
Let's
will
take
prefer
the patient had
CRRT.
a low dose to moderate level of NORAC, and you have a hypokalemia around 6. Will
Now,
you?
I will make it easier, the
I will
answer
do
for you,
sled then.
Raku.
I will do sled.
The idea is that the CRRT's specific indications are: one is this sepsis related, second is intracerebral edema, which is more common in ALF and others. But in HRS, there is no consideration for cerebral edema, right, on that part. So, if your patient can tolerate, and if you can manage with an extended sled itself, if there are the financials are there, then you can this extended sled, sled F can be your good alternative, can be your poor man's alternative itself, we can say so. But if you say sled is anyway now preferred choice, particularly of your renal preservation, then we are slower or not altering the hemodynamics itself, then better middle molecule clearance. But if you see in our practical experience, most of the times the CRRT may not give you a very quicker improvement in the biochemical parameters itself. We struggle with the clearance of the acidosis, betterment of the acidosis or clearance of the potassium, lactates. We struggle to clear the lactate itself. Obviously, lower flow and everything results in that. So this is a tricky clinical decisions, and that is why we are conducting all these CCN sessions itself, right? So we will get to know the answers itself. So you have to stay with us and regularly join to learn about it.
Just a comment, Dr. Amber here from Nephrology. CRT, giving CRT also for such patients of HRS, it is might reverse the might be beneficial in HRS physiology. It is yet to be seen. But most of these patients, unless they go for a liver transplant, it can only be a bridge to a liver transplant. It cannot be the ultimate therapy because such patients have to finally, even patients who undergo a liver transplant, perioperatively we see that they require CRRT, especially at creates of 2.5. And HRS physiology is operating in most of patients of decom CLD in a background status because they always have that splanchnic vasodilation and they have blood pressures which are hovering less than 100. And the HRS diagnosis itself is a diagnosis of exclusion. So a lot of times there are no clear-cut ways of establishing whether it is an HRI or it is some HRS, which is a functional, plus some associated intrinsic renal also issues. Very tough to clear-cut make a demarcation. So I think hence the 2024 guidelines have also asked for early resuscitation and to take a decision within 24 hours rather than go beyond 24 hours and wait to actually establish an etiology. So basically, I think if patients are willing for transplant, then it will be the most beneficial because most of the studies have shown that the mortality at 1 month without any kind of liver transplantation is almost as high as 90 to 100%. If they don't go for a liver transplant, especially in cases of HRS1, which was a very fulminant kind of presentation.
We have understood that part. And I was also very intrigued on this. I thank Gaurav to put this up, the melt paradox itself, because in fact I have invited me to join. Unfortunately, he is yet to join, but we will take this question later on also. But this is a very common phenomenon because when your creatinine improves and the MELD score goes down, there is an eternal dilemma not only from the clinicians but also from the patient's family members. They always calculate the MELD itself, and they think they are now off the list or they have still some time. So in fact, so whether there is, we will discuss about that, whether there is a modified scoring system or we negate the MELD over there or we take the previous MELD before everything happened to be criteria for the transplantation. I don't know the answer itself, but this is an practical situation we do. Thanks for highlighting this point also. Any comment from Kushal or anyone? Do you have NGAL in our center? Yes, Raku. Even NGAL are nowadays available in as a point of care too, right? But it is yet to
Hello.
be completely assimilated into our practice itself.
Yes, sir.
We should start monitoring the NGAL levels of our HRS patients to see for the trend and with the with the recovery it reflects.
Yes, sir. हाँ जी. Yeah, Dr. Gaurav, one question. We are talking about the diagnosis and the treatment of HRS. About the prevention of HRS, a lot of studies are, articles are there regarding role of pentoxifylline, Trental, and one nebivolol, this is the third generation beta blocker. So, in the prevention of HRS, what is your take on that? We are already using in CLD patient for a prophylaxis of GI bleed. We are already using propranolol and carvedilol. So now about nebivolol and pentoxifylline for the prevention of HRS. So what do you take on that?
For the beta blockers, the carvedilol and propranolol both has been like previously shown to decrease the portal hypertension and decrease the like chances of GI bleed, varicose bleeds. Regarding the nebivolol, sir, I actually have to see like what all literature is there because it has got additional nitric oxide property also. So how
I think
effectively
Manish,
it is there, we'll see.
I think we will have a HRS from this was one more of a nephrologist perspective, because Gaurav is a primarily nephrologist. HRS is such a important day. We will have a three triple A. We will have a hepatologist perspective, and eventually we'll summarize with a critical care perspective too. Right. So then I think the entire spectrum would be covered itself. This is a very relevant question that you have asked, and most of your questions are also very difficult to answer itself, particularly. So we will take this question in the subsequent day. We'll discuss about it. Very
Okay,
important part.
thank you.
Kits available, best test name, turnaround time. I will let you know tomorrow way. But your urinary and serum NGAL are available, which is a standard turnaround time. Raku. To answer you, anyone else? I can see Chandrima, like all our Bengali people, very prone to ask questions. Trishita, you want to ask any questions? No. Okay, so if there is none, I think we will meet next Thursday. One of us will from critical care nephrology, particularly critical care person. I will allocate to come up with a good topic itself, and by Saturday we will announce the topic of the next class. Maybe we will also form I wish to do a proper team bet or a debate itself. That would be Trishita will be given responsibility to organize a team bet, right, between the nephrology and critical care on a topic on CCN itself. So you will moderate that session. So we will do it in sometime soon. And my request to also the presenters itself to put some quizzes also, some MCQ based questions. I think that would be also make things interesting, right? It's a gamification of the education itself, where people like to answer questions in that. Nowadays, it is not that difficult to make some good questions out of the way. And if and also for the benefit of the student itself, if you can give a little references of the good review articles that can be read, couple of way. It may not all the you don't have to cite all the references or the studies itself, right? Because you cannot read all the studies, but maybe if some good narrative review or standard reviews in a good index journal, which can suffice the follow-up reading, that would be very useful for the students itself, because you have definitely gone through the entire literature review and you have downloaded most of them. So if you can please help whosoever is preparing the or presenting or preparing the slides, if you can at the last slide add some questions, quiz questions, and the references, couple of references, that would be very good on that part. So this is the post discharge trajectory. You want to cover this or you already did? बोला ना हाँ he did. Okay, हाँ ठीक है. Okay, fair enough. I thought you want to cover that day. So see you next Thursday, and thanks to everyone for joining. Thanks to making it interactive, resurrective, and everyone who have asked question would be invited to take lectures also. So Manish, Raku, Kushal, all of you are next in the line to present. So thank you, and let's have a great weekend ahead. Bye. Good night.